Hi everyone, my name is Rachel Moses and you are listening to the AHP Leader podcast, and today I am delighted that we have a full day on cardio-respiratory rehabilitation during COVID-19, and this is really an update session, and the people that are very kindly giving up their time for free today are not proclaimed experts in their field. Some of them may well be, but what they've agreed to do is share some of their experiences and how they've adapted during the pandemic, because there's a lot of people out there struggling. So none of the speakers are claiming this is the only way or this might be the completely right way. It's just the way they've adapted. And I know there's many of you listening from all over the world actually, which is incredible. So please use the chat function on YouTube. You do have to be signed in to be able to use the chat, but for those of you watching live, the speakers will have a Q&A at the end of their session. And also you can use Twitter as a handle, but you just must tag me in or DM me. My DMs are open, so you can ask questions that way. They're the two best ways to ask questions. Obviously, you won't be able to interact with the speakers as the way we'll have it set up, but I'm delighted that people are giving up their time. So let's crack on. The sessions are in hour chunks. This is the first hour, and I'm delighted to introduce our first speaker, who is Sue. Now, she's going to share her slides and introduce herself. So thanks very much, Sue.
Okay. Okay, so yeah, my name's Sue. I'm a physio. I'm based in South Wales. I also sit on the exec committee for the ACPICR, which is the Association of Chartered Physiotherapists in Cardiovascular Rehab. And I've been asked to present today on behalf of ACPICR about some of the various guidelines and advice that's out there to support those of us working in cardiac rehab to continue to deliver our services during the pandemic. I'll be focusing mainly on the cardiac rehab focused guidance. I believe Laura is talking a little bit later this morning, and she will include some of the more pulmonary rehab focused guidance. So I'll focus more on the cardiac rehab side of things, and it might not include everything. There's a lot of guidance out there. There's a lot to go over. So I've just tried to pick out some of the key documents that might help different services depending on what stage they're at. So I always find it helpful to start from the beginning and just to do a bit of a sum up of where we are so far. And this slide simplifies things massively and makes it look like it's been a very linear process of lockdown happening and then gradually building back services to get to a point where we're reintroducing some face-to-face services. And that isn't the case at all. It's been a very busy and a very overwhelming time. And most of us are trying to develop remote arms of delivery. We recognise that there's benefits to remote delivery of our services in terms of making cardiac rehab more accessible and giving patients choice. So we're trying to develop that side of things whilst also trying to plan for the safe return of face-to-face activity. And those things are happening at the same time. So it's a very busy time. But if we go back to the beginning, so at the start of the first lockdown in March, all face-to-face cardiac rehab activity was stopped. Many services had their staff, all of their staff redeployed and weren't able to offer a service at all. Some services managed to retain some staff, so were able to continue delivering some elements of cardiac rehab. So they may have retained some of their nurses, or they may have retained some of their exercise staff, or a combination of the two, and were able to offer something, but not everything. Other services, and unfortunately this was the case where I worked, we were able to retain most of our staff, so we were still able to deliver most components of comprehensive cardiac rehab. So we were in a fortunate position, but as you can see, there was already a lot of variation in what was being delivered right from the start of the pandemic, really. So those of us that were able to continue running, we were able to do so really because we met the criteria of being an essential service. It's well documented that cardiac rehab prevents admissions. We also provide the main follow-up for many of our patients. So for example, patients that have had a heart attack and had a stent fitted, they won't necessarily have any follow-up with cardiology. Their main follow-up will happen with us in cardiac rehab. So for those reasons, we were classified as an essential service and we were able to keep running. So for those of us whose service was able to keep running, we had to make a very rapid switch to delivering everything remotely, which was very different to how things looked before the pandemic. So prior to COVID, there was some home-based cardiac rehab offered, but the vast majority of it was delivered through face-to-face centre-based rehab. So making that switch to delivering everything remotely was quite an undertaking. Fortunately, in cardiac rehab, we did have lots of resources available to us, robust resources that we could use to support home delivery. So there's lots of heart manuals and websites, app-based resources that we had that we could potentially use. And we do have good evidence that actually home-based cardiac rehab can be as effective as centre-based as long as it's comprehensive. So we were fortunate in that way, but it was just a big undertaking to sort of deliver that to all of our patients. We weren't quite at a stage where we were ready for that. So some services have really recognised the benefits of remote delivery in terms of it's allowed us to sort of some of the more hard to reach groups to access cardiac rehab that didn't before. So for instance, people that live in very remote places or people that have gone back to work, accessing cardiac rehab remotely actually some centres have really sort of embraced remote delivery and taken that forward. So they've started to develop it further and introduce video consultation for assessing patients and loaning out activity trackers and blood pressure machines so that they can get some measures from the patients as to how they're responding to their rehab, developing things further in terms of pre-recording some exercise and education resources, and even taking it one step further and now working towards delivering live exercise classes and education sessions, group education sessions via video consultation. So that side of things has really been embraced. Other services are focused more on trying to reintroduce put plans in place to safely bring back face-to-face services. So starting off with bringing back face-to-face assessment and then building that on to reintroducing face-to-face groups. Some centres are trying to do a bit of both. So again, there's a real variation in the journey that different services have had and the stage that they're at now. And then when you add to that the fact that the restrictions across all the 4 nations in the UK are really quite different. So where I am in Wales, we've just come out of a just over 2-week fire break lockdown. So some restrictions are still in place, but we've come out of that lockdown, whereas England have just gone into a full lockdown. So there's a lot of variety as to what's happening across the board, and it is quite a confusing picture. So in terms of what guidance is out there, so for those services that are just at the point of trying to get back any service at all, the BACPR, so that's the British Association for Cardiovascular Prevention and Rehab, in conjunction with the British Cardiology Society and the British Heart Foundation, they put together this joint position statement, and that really emphasises the fact that cardiac rehab services need to be retained. And if they haven't been retained, they need to be reinstated as soon as possible. And it lays out sort of what they would consider to be the minimum provision of cardiac rehab. So if your service has got very limited resources, this is the bare minimum of what you should be aiming for. And that was published back in May. And then the BACPR have also, the exercise professionals group from BACPR have also produced a guidance document relating to the exercise component of cardiac rehab during the pandemic. So the first iteration of this was developed during the first lockdown when things were being done completely remotely. And the focus was really on safety. So assessing patients remotely was completely alien to us as exercise professionals in cardiac rehab. We were very used to having physical measures to base our exercise prescription on. So this document really sort of outlined how it could be possible to do a comprehensive assessment remotely, what tools to use and what to look out for, and then how you can use that to give some form of an exercise plan. And then this document has since been updated. So the updated version was published at the beginning of this month. And the focus has shifted now a little bit towards the effectiveness of our service. So this pandemic isn't going anywhere fast. It's right to think about safety, but we also really need to start thinking about how effective our service is. So from that point of view, if your service is really focusing on the remote delivery, there's guidance in there as to how to do that as effectively and safely as possible. Whereas if your service is looking at getting back some face-to-face services, because the information that we can get from a face-to-face assessment can really enhance and optimize our exercise prescription. So if that's the route that your service is going down, then there's some guidance in there as to how you can reintroduce that safely. So next, I'm going to come on to some American guidance. And initially, I was trying to focus just on UK guidance, just to make it as useful and as relevant as possible. But this document by the AACVPR, which is the American Association for Cardiovascular and Pulmonary Rehab, it's got some really interesting points in it, actually. So these are considerations for resuming centre-based rehab. And it's got the usual stuff that you would expect to see about limiting numbers and risk assessing patients and staff and adequate PPE and the stuff that you would expect to read. But there's also a few really interesting points in there as well, which I've picked out for this slide. So they state that when deciding which patients to bring in for face-to-face, we really need to focus on the patients with the greatest need and those who may derive the greatest benefit. So patients with the greatest need, I think we can all sort of identify that remote rehab just doesn't work for some groups of patients. So I'm thinking possibly patients with sensory impairments, hearing impairments. Remote delivery is really a challenge for those groups of patients. Patients that have been referred to cardiac rehab that might have had COVID. We really need to be quite careful in our screening of those patients and monitoring to make sure that we're looking out for any signs of post-viral syndrome. Patients who are having ongoing cardiac symptoms, we really need to look at what's happening with those patients. So those might be the ones that we prioritise to bring in for a face-to-face appointment. And those who may derive the greatest benefit. So, patients who are anxious, they really would benefit from actually having that face-to-face contact. Or patients who have got complex comorbidities, we know that our exercise prescription can probably be enhanced by bringing them in for a face-to-face appointment. Another point in this document, so obviously we're looking at screening our patients, both in terms of risk assessing the patients for their risk of complications if they were to get COVID from being brought into centre-based rehab, and also doing some screening to make sure that they haven't got any symptoms of COVID before we bring them into the centre. But we also need to think about screening patients for their ability to comply with the processes that we've put in place. So is that patient going to be compliant with social distancing and hand hygiene? Are they going to accurately and honestly respond to any pre-programmed screening tools that you're using? Because not all patients are able to do those things, and for the safety of the other patients and for the staff, we do really need to make sure that patients are going to be able to comply with those procedures. This document also gives us that reassurance that it's fine to start off with lower numbers in the beginning. So we need to get the processes right. So there's no pressure to get straight in there at your maximum capacity numbers and get things up and running. Just start off with lower numbers to begin with and get the process right and make sure that everyone's happy and comfortable with what needs to be done to do things safely. And the last point, which I thought was really valuable, was that we really need to balance the reintroduction of face-to-face services with the home-based approaches that we're using. So I think most of us have found that delivering rehab remotely is more time-consuming. So if we're still offering that, but we're also trying to bring back some face-to-face activity, which in itself will be more time consuming than it was previously, because there's a lot more cleaning that needs to be done and screening. We really need to think carefully about what staff and resources we have and how we can manage the two approaches simultaneously. So thinking now to guidance that's been published during the more recent lockdowns in the UK. So as I mentioned, England has just gone back into its second full lockdown, or lockdown 2.0, I think it's sometimes referred to as. And prior to this, the CSPs, this is the Chartered Society of Physiotherapy, they recognised that stopping physiotherapy services during the lockdown actually had a really significant knock-on effect. So they released this guidance ahead of the November lockdown to say, look, physiotherapy services really need to keep running this time, unless explicitly instructed to stop by the government. And there's some specific guidance. If your physio service is based in a gym, there's some guidance relating to that. But this guidance is for England only. It explicitly states that it doesn't apply to Wales, Northern Ireland and Scotland because different restrictions are in place there. And so I think that really exemplifies what's going on at the moment. There's not a one-size-fits-all golden document that I can give you that's going to be applicable to everyone. It just doesn't exist. All we can do is use the various guidance that I've shared with you so far, which give checklists of how you can reintroduce things safely. But those have to be used in the context of whatever your local restrictions are. So I think, like I say, in Wales, we've just come out of a fire break lockdown, so some restrictions are still in place. England has gone into a full lockdown. In Scotland, I believe there's a level system, so depending on what level your region is at, that will dictate what the restrictions are. And again, in Northern Ireland, there's restrictions in place as well. So you really need to use any guidelines in conjunction with whatever the national restrictions are at that time, plus using both of those things in conjunction with whatever your health board or organisation's local infection prevention and control policies are, and what your organisation's priorities are really. So the reintroduction of face-to-face services in a rural community NHS trust are likely to look a bit different to what the reintroduction of services in a city acute NHS trust. The two are going to look very different. So all three of those things need to be used when looking at reintroducing services. Having said that, I do want to just bring your attention to this Welsh document because there's some really good stuff coming out of Wales, and not just I'm a celebrity, get me out of here. I really like this this particular document. This was published at in October of this year. Because this really values the importance of therapeutic groups. It recognises again that infection prevention and control has to be at the forefront, of course it does. And it recognises that remote delivery is still appropriate for some groups of patients. That should still be the default for many groups of patients. It's definitely still a viable option. But we need to really be careful that we're not excluding groups of patients who can't access remote delivery, because often those groups of patients are the most vulnerable groups. So it might be groups of patients who simply can't afford the resources that are required to access digital remote delivery, or it might be patients who have learning disabilities, and for them remote delivery isn't appropriate. So we need to really make sure that we're not excluding those groups of patients as well. So in terms of moving forward, there's clearly a lot of work still to be done. Obviously, we need to continue to develop remote delivery of our services. Absolutely, it's fundamental that we do that. We know that it could potentially help us to increase uptake, and it means that we have patients have a choice as to how they access their rehab. So we need more research into remote delivery and these digital options and how effective they are. But we also need to make sure that cardiac rehab remains truly accessible to everyone. And that means we do need to think about reintroducing some face-to-face activity, but not just for that reason, but also in terms of the effectiveness of our service. We need to make sure that we know that the information we get from a face-to-face assessment in terms of the exercise part of cardiac rehab, that really enhances and optimizes our exercise prescription. So it's really important that we bring back face-to-face activity for that reason as well. So finally, just to acknowledge some of the other committee members based up over in England and up in Scotland who've helped give me a national picture, and also Maria Mooney, who's based over in Belfast. She sort of gave me lots of really helpful information as to what things look like over in Northern Ireland. I hope that's been helpful. I'm happy to take any questions, but if anyone's watching this after the event, my email address is there, as is the email address for ACPICR if any queries want to be emailed to us. Thanks very much.
Thank you so much, Sue. That was amazing. I think I'm going to consolidate a couple of questions, and it was almost predictable in some ways about some of the challenges that the clinicians actually have is managers or people with power understanding that these services can continue and are safe for continuing. And this whole day is around how we can keep services operational in a COVID pandemic. So what advice do you have in terms of if you can present the evidence, you can present the guidelines, you can present the opinions, but people are just being blocked by saying no? I presume because it's the easiest option for a manager to say no, it's not safe. So what's a different way for people to approach it?
I think just really sort of thinking through how it can be done safely. So putting the risk, thinking about what risk assessments would need to be done, really sort of looking at pulling together. So where I work, we're looking at pulling together an SOP, a standard operating procedure of what it will look like when we bring back face-to-face services. So we're not in a position to resume them as yet for various different reasons. But we've got the plans there to show that it can be done safely, so that when we have the green light, we can say, right, this is what it will look like. So I think really just thinking through how it can be done safely is the most, it's all the planning that goes on behind the scenes. That's the time consuming bit. Actually then going on and bringing patients back and doing the face-to-face is the easy part, really. It's the planning that needs to be done ahead of that. So if that can be done in advance, it means that when you eventually do have the green light, you can get things up and running as quickly as possible.
Absolutely. And that kind of links into this next question, which was, how much support or input did you need from IPC, so infection prevention control, or board level to get going? Or were you able to do it with cardiac rehab?
No, we've involved infection prevention and control. So our service is still at the planning stage. We haven't, we've reintroduced some face-to-face assessments, some face-to-face clinics, but in terms of classes and groups, we're not at that stage yet. We're still planning for that. But for both arms, we've absolutely involved infection prevention, and it's just been really helpful. Just little things about, thinking about how we wash our heart rate monitors, and does that need to be done differently in light of, and actually, the advice was to do things slightly differently. So it's not just about ticking a box. Actually, it's just a really useful thing to have those links and to get that information from the people that this is their bread and butter, really.
I think the turning point for me maybe was when Boris announced that the NHS is open business, and that was quickly supported by the Health Secretary. And I know I'm very much England centric because I work in England, but that was certainly the message of all the devolved nations. So when that statement came to me as a respiratory clinician, as a respiratory manager, I think it was like, right, okay, we now need to understand how we can safely do this. So from a cardiac rehab perspective, I mean, it's important just to remind people how important this intervention is.
Yeah, absolutely. Yeah.
So in a nutshell, if you were that manager leader and you were having to, in a couple of sentences, say why cardiac rehab needs to continue, what would you say? What would be like your elevator pitch on the spot?
Yeah, I mean, I am a physio, so I am more focused on the exercise component of cardiac rehab. And obviously cardiac rehab is so much more than just the exercise. But in terms of the exercise, our exercise prescription is optimized and enhanced infinitely by seeing a patient face to face. It isn't the same assessing a patient remotely. We can still offer something, we can still give some really good advice, but in terms of an individualized, effective program of exercise, we need that face-to-face assessment and monitoring. So that's why it's really important that we bring it back. But also, anecdotally, we're definitely seeing that patients are becoming, the longer this is going on, patients are becoming more anxious. You know, they're becoming more fearful. They're avoiding activity. They're avoiding going in gyms. They're avoiding using the NHS, and that's having real knock-on consequences. And you know, there's a huge rehab need that's come off this pandemic. So it's vital that we start bringing those services back. Absolutely, I 100% believe that.
Thank you. And there's a comment from Matthew about how are you monitoring patients remotely? Now, we do have a whole session on virtual delivery, but do you want to answer that question from your perspective?
Yeah, absolutely. I mean, there's lots of different ways, and if I can just signpost you to that BACPR Exercise Professionals Group guidance document, because that outlines it quite comprehensively. But you know, in cardiac rehab, we use Borg scales, effort scales, and you can still use those remotely. You can still ring a patient and ask them what their effort scores have been for a particular exercise, and that gives you a lot of useful information to progress it. Just asking them how they're feeling with their activity and exercise. You know, are they feeling unduly tired, or you know, is it feeling easy? Lots of patients these days have activity trackers and Fitbits which have got heart rate monitors on them, so we can use those. There's lots of materials out there that we can use to help monitor patients, but I'd signpost him to that document because it outlines it quite comprehensively.
Thank you so much. Well, we are bang on time here, so I just want to say a massive thank you to Sue. Now, I am going to start admitting the next speakers, but I think, Sue, one of the big things for me in this is how cardiac rehab and pulmonary rehab have come together as well.
Yeah, absolutely.
Now, I don't think it was intentional that they've always been completely separate, but certainly in my organisation, that's just been a really nice thing, and how we've actually, like, you know, co-produced documents, risk assessments. There's so much overlap.
Yeah, absolutely.
So I think that needs to continue, doesn't it?
Definitely. There was a need for that anyway. You know, there's some great work being done over in Leicester with Sally Singh. She does combined rehab, and up in Scotland they're doing multi-morbidity rehab programs. I think there was going to be a movement towards that anyway, but as you say, certainly this has built up the foundations for joint working, so hopefully that will continue. I really hope so.
Absolutely. And there's so many legends in this field, isn't there?
Yeah,
absolutely. And legends create legends. So I'm really grateful of your time, Sue. Thanks so much. Enjoy the rest of your day.
Thank you.
So I'm delighted to have the next speakers here. Now, this is like a multi-act of experts, where you guys are experts in your field. So I'm really chuffed that the Physios for ME have joined us today, because this is a really fundamental and really important part of COVID-19. And I know you guys have been passionate about this from the start. And this is going to be about who not to exercise, but who still needs rehab. So I'm not going to steal your time anymore. This is a half-hour session. Everyone, thanks, guys, for the questions coming through on YouTube and on Twitter. Please continue them. And I'm going to give these guys the floor and ask them to introduce themselves.
Thanks very much, Rachel. And I'm sorry that I'm a bit in the dark. I can't seem to adjust it. It was fine before I came on. So luckily, I'm only going to say a few words at the beginning. So I'm Michelle, and I'm going to be here today with Nikki and Natalie from Physios for ME. We're going to whistle through this at a breakneck speed. So if we will share the slides afterwards, and there is plenty more information on our website if you want to go and look at anything that you think that we didn't spend enough time on for you. So when is exercise indicated? Isn't indicated, but rehab is. So
Michelle, can I just check they can see the slides? Michelle,
yeah, they're up.
Yeah, okay.
So our background is very much around a sort of exercise rehab background until we really came professionally and personally involved with ME. And then we realised that we needed to look at this from a different perspective. And we came together with Karen as well as Physios for ME last year. What we're going to talk about today is some of our learning around post-viral fatigue syndrome and ME and how that could help us learn around how we manage our patients post-COVID-19 and looking at long COVID. So, COVID, what do we know so far? I think for me, it's been really interesting seeing a whole new condition come along and how as clinicians we've had to learn from what we know about other conditions to help us treat and manage a condition we know nothing about. And we've definitely seen that through the acute phase, and now we're moving on very much to the same with long COVID. The National Institute for Health Research has indicated that they think these long COVID symptoms might be due to 4 different syndromes, and we're going to talk very much around today around the last one, the post-viral fatigue syndrome. So what is the incidence of post-viral fatigue syndrome? Well, we're not entirely clear due to the lack of testing at the beginning of the pandemic, but we do know from some of the other epidemics previously that up to 10% of people post-viral can go on to develop post-viral syndrome / ME. So I think we're dealing with quite a large chunk of people, and you can see from some of the groups that we've put up here, they've got large numbers of members. And what are the symptoms? Who are these people? Well, really interestingly for me, it's over 80% of them are those who aren't admitted to hospital. So they're not known to us. They're not coming through the pathways of seen in ITU, seen on the ward and referred through to rehab. They're sitting in the community, and they're the ones who are going on to develop post-viral fatigue syndrome and long COVID-19. And the majority are young and were moderately to very physically active before COVID came along. And what are the symptoms that they're talking about? Well, 89% of them are talking about fluctuating symptoms, and the top 3 symptoms being shortness of breath, tightness of chest, and fatigue. And when we overlay those against the common ME chronic fatigue syndrome symptoms, you can see there's a real close match, particularly with that fatigue, muscle body ache, the difficulty in concentrating, the brain fog, if people have heard that as an expression. So I think it's clear that there is some learning that we can get from ME, and particularly relating to fatigue. So I'm going to hand over to Nikki, who's going to talk about fatigue.
Thanks, Michelle. So we know that fatigue, we're talking about an overwhelming sense of fatigue, and there's a lot of research being done on fatigue by particularly Krupp, and it's worth looking at her work. But we're going to focus in on particularly central fatigue and peripheral fatigue in relation to ME. Now, all of this information that I'm going to present is particularly related to ME, so it's really difficult to know if this is pertinent for long COVID, particularly post-viral fatigue syndrome related to long COVID. But we certainly, as we're treating people with long COVID, it certainly seems to be the lessons we're learning from people with ME are helping for people with long COVID. We know that fatigue can be as a result of respiratory problems, cardiac problems, but as I say, we're going to focus more on central and peripheral fatigue. As I say, we know that fatigue can be caused directly by the infection itself, the increased cytokines, the effect that these have on sleep in particular. But we also know now that COVID-19 can invade the brain. It can cross the blood-brain barrier, affecting the glial cells, causing encephalopathies, inflammatory central nervous system problems, strokes. Infections can lead to this hyper-alert state and also a hypoxic brain injury as well. So lots of neurological conditions are now being seen in our long COVID population. Looking at the fatigue research, we know that there's evidence to show that there's reduction in brainstem perfusion, there's reduced frontal lobe activity because of deficits from the perfusion and also deficit from glucose uptake. We also know there's been work done with ME populations looking at using brain scans and seeing an increase in acidosis, and the
proposal is that this is due to damage to the mitochondria, leading to an increased anaerobic metabolism, leading to this acidosis. And they certainly see in the dorsal root ganglion neurons that will respond to these low pH levels and also low ATP levels as well. We can also see from research that there's an increase in serotonin, a decrease in dopamine, and these neurotransmitters obviously link in with the endocrine system and cause changes to the endocrine system as well. So the dopamine and serotonin innervate the hypothalamus, and dopamine actually inhibits the anterior pituitary gland. So again, that can link in to the control of this hypothalamic pituitary adrenal axis and the impact that that has on stress levels or response to stress levels. And obviously the hypothalamus is very much responsible for control of temperature, homeostasis, sleep problems. And again, we're seeing all of these changes with our long COVID and our ME populations. On top of that, we're seeing changes in the autonomic nervous system, and unfortunately, we see a lot of dysautonomia in our ME populations and possibly in our long COVID population as well. Some research shows that up to 80% of people with ME have autonomic nervous system problems, obviously resulting in blood pressure changes, respiratory rate changes, heart rate changes, and these orthostatic intolerances, POTS, chronic CI, neurally mediated hypotension, and lots of other autonomic changes that we see in our ME population and we need to be looking out for in our long COVID population. So those are some of the central possible causes of fatigue. When we look at the peripheral causes, the big one is in relation to mitochondria, and certainly more and more evidence over the last couple of years have shown that with people with ME, they've definitely got abnormal mitochondria, which has been shown to affect the aerobic capacity, the metabolism within the mitochondria, and leading to them switching to anaerobic metabolism a lot quicker. And also they seem to have a reduced ATP production. So once they've broken down the ATP to ADP, they can't seem to switch it back into ATP again. So this results in a high level of acidosis in the mitochondria, in the muscles, and also because anywhere that requires energy, so that includes the brain as well, you'll see an increase in acidosis wherever the energy is required. So exercise in this situation could potentially make this a lot worse. So just I'm just going to flick through these slides. These slides are from the ICC, which is ME piece of research that is really sort of guideline really, and the information is in the references at the back, but it's really all about properly differentially diagnosing the fatigue. And so instead of just doing your usual bloods and your usual x-rays, we really need to be digging into what could be causing this patient's fatigue, and not just assuming it's as a result of cardiac problems or respiratory problems, but potentially there's other things going on. And on our website we produced this let's go back, chart which differentiates between post-viral fatigue syndrome and ME, and there are some overlaps, but the defining thing for ME is this post-exertional malaise. So post-exertional malaise, or it can be called post-exertional neuroimmune exhaustion, it's very much about having this marked decrease in physical and cognitive fatigability after exertion. And the important thing is it's delayed, so up to 72 hours. So we need to be monitoring that in our patients to make sure we're aware of what's happening. And it's not just fatigue. It's the important thing is they've done research and they've identified there's so many different symptoms, up to 30 symptoms that can relate to this post-exertional malaise. Fatigue obviously is the big one, but there's a lot related to cognitive activity in terms of concentration, memory, headaches, and so on. So really important to monitor that. And there's been a lot of research by the Workwell Foundation in America that have identified on CPET testing that this post-exertional malaise seems to be linked with them switching early into this anaerobic threshold. So they've done lots of VO2 max testing for lots and lots of people with ME. We don't know if this applies to it with the COVID population, but certainly we need to be aware that their VO2 max is significantly reduced in the ME population, and as I say, they switch very quickly into their anaerobic metabolism. In addition to that, the Workwell Foundation and lots of other researchers now, particularly in America, but some in Scandinavia, have been looking at 2-day CPET tests where they've found that compared to healthy controls, people with ME, on the first day they have got reduced VO2 max, they have got a reduced anaerobic threshold, but this is reduced even more on the second day, seeming to indicate the PEM that they're suffering from on the second day compared to controls, and also this increase in acidosis on the second day. So, and this was particularly seen with Lien in Scandinavia. Over to Natalie now.
Thank you, Nikki, for your whistle-stop tour. Yeah, all these slides will be available afterwards. So identifying this subset of patients is really critical for our patient safety. So we put this slide on our website back in June when we were understanding that physios were beginning to see patients with potential post-viral fatigue syndrome. And here's just a few bits on this slide about what to look for. So activity-induced fatigue, intermittent and recurring flare of viral symptoms, unable to maintain previous levels of activity, unrefreshing sleep, cognitive problems, orthostatic intolerances. And this is when there's a flag to say that standard rehabilitation or exercise may be detrimental. We also then put this slide on our website just to give physios some idea of management strategies for this group. Again, from a safety point of view, because we knew that post-viral fatigue syndrome can develop into long-term ME, which we wanted to, avoid as much as possible for these patients. So talking about some of the key management strategies from a physio point of view, usual objective assessment from a fatigue point of view, looking at the cardio-respiratory issues, strength, tone, sensation, coordination, pain, looking at blood pressure, heart rate, respiratory rate, oxygen levels, etc. Most importantly, this subset of patients, I think it's a subjective assessment that's the most important, because it's the things that they say in the subjective that are going to, flag this kind of what's going on here. Is exercise appropriate? And particularly the activity related to post-exertional malaise, as Nikki spoke of. So some of those examples that you're looking for are patients talking about this relapsing remitting pattern, or the boom-bust cycle, or they're not being able to sustain everyday activity. So they might be saying to you, I'm resting at the weekends to kind of recover from the week. Responding well to doing less and resting more is another kind of flag, and doing too much causes a flare or relapse. So there's a few quotes on here from some of my current long COVID patients. The first one, I can clearly see there are phases of good followed by phases of bad, where I'm forced to do less. This leads to a good phase and the cycle repeats. When I crash, I can't find the energy to fuel my muscles at all. 5 weeks ago, I started doing 10 to 15-minute walks every evening. I got worse, slower, and was shuffling. I walked to the end of the road and back, 10 houses there and back with a rest. I ended up 3 days lying down, couldn't cook or clean. Resting for short periods in the day has been a revelation. These are just some of the things that you might be looking for. Just a slide of some of the outcome measures you can use for measuring fatigue. I won't go over them, we don't have the time. So in terms of management, one really important tool is for the patient to do an activity rest and symptom diary. So they're tracking their activity and rest over 2 weeks to find a baseline. It helps the patient to track back previous days if there has been a symptom flare. And that's obviously particularly important for these patients who are having post-exertional malaise, where there's a delay in their symptom, as Nikki said, sometimes up to 72 hours later. A bearable app, if your patient is high tech, it's a good app you can have a look at where you can monitor symptoms. And so other management strategies really are how to base, plan and prioritise for this patient group. Establishing the baseline, as I said, over 2 weeks, and this is for physical and cognitive activity. Encouraging small rest breaks throughout the day, and this is for restorative rest, a healing rest, allowing the body the chance to heal. Changing activities from cognitive to physical activities, that's called switching, can often be a useful strategy. Breaking down activities, so if someone needs to do some cleaning things out, have a rest, wipe the sink, have a rest, things like that. And there's other energy conservation methods, such as thinking about body positions. We know that sitting conserves about 25% more energy than standing. Using electric toothbrushes, things like that. Using timers, particularly useful for cognitive activity, such as computer work. Setting a timer before their symptom exacerbation. Prioritising, planning. Royal College of Occupational Therapists have put some great guidance on their website on 3 Ps, pacing, planning and prioritising. And also some great work from the ME Association on post-viral fatigue. Pacing is also a bit like an energy budget, I think, and this is quite a good thing to explain to your patients. Really, there's 4 different types of energy accounts that are needed. Energy as a priority for essential activities of daily living. There's an emergency fund for unexpected events. Then there's a sharing fund. So this is for social activity, and that's a really important one that we can't really miss out in the overall energy budget. And a savings investment, so saving a little bit of energy every day to invest in future health, and I think that's where the rest can come in. Again, some general fatigue management, which we've talked about. There's other things, sleep, nutrition, food, emotional health, incredibly important. Cognition, leisure time, pain management if it's a problem, activity management, heart rate monitoring, which Michelle is going to touch on in a little while. So what about rehab? So if a patient already has a limited energy budget, adding in any aerobic or structured exercise may push the bank into deficit. This is where we could see a setback, a flare or a relapse. But there is a time and a place for rehab. I think the rehab we're talking about here is a slow, careful process. For example, I have a patient at the moment on COVID, 8 months post-infection, functioning at 20 to 30% pre-COVID levels. He's able to walk 5 minutes in the morning and the afternoon below his anaerobic threshold, 3 20-minute periods of cognitive activity. I started him on gentle stretches in supine for 2 months, stabilised his symptoms, no flares. Only really in the last month started on 3 reps of isometric muscle contractions, only with 1 minute rest in between each contraction. You can see how slow it might be. As a patient, I'm running out of time, so I'm going to let you read this. This was an OT who was referred to pulmonary rehab, and it basically didn't work. It was too intense for her. So main advice there, quickly talking about the NICE draft guidelines for ME, who are now not promoting graded exercise therapy. Again, you can see the draft guidance, it's worth a read. Okay, Michelle, over to you quickly.
Thanks, Natalie. So I'm literally just going to, I thought it would be really useful to touch on heart rate monitoring, because that's something I know from when I used to work in cardiac rehab, we used to use a lot. And Natalie's mentioned how it is a useful tool for some of our patients with ME. And I think it's worth, we've done an in-depth podcast on heart rate monitoring with some patients talking about their experience as well. It's well worth a listen, and we found a lot of professionals and patients have found it really, really useful. to learn more. But I think it's really important to remember that CPET testing that Nikki talked about, how people with ME have that lower anaerobic threshold, so they move into their anaerobic respiration a lot quicker than we might see with our traditional patients. So the evidence talks about the way we've been working talks about using their anaerobic threshold at 50% of their maximum heart rate. But interestingly, there's some hot off the press information from Workwell out from America, where they're talking about using 15 beats per minute added to a patient's resting heart rate. And that's such a small window for aerobic activity. And I think that really reinforces the point that Natalie just made around how this is really slow progress, and that actually traditional approach to rehab could push them up over that threshold. And we really found that our work, it's around keeping people below their anaerobic threshold and avoiding that triggering their post-exertional malaise that Nikki mentioned. So just to sum up our talk in brief, we know there's 4 types of long COVID, and one of those being post-viral fatigue syndrome. So we could have some really useful lessons, and hopefully the information we've talked to you about relating to ME will provide you with some indications. And we're certainly seeing that using that knowledge from ME is helping us manage people with long COVID. The whistle-stop tour through the physiology, and Natalie's talked brilliantly about the sort of strategies for pacing, rest and relaxation. We didn't really have time to talk about sleep management of food and nutrition, but there is a lot there around that as well. And just really to summarise on that, due to the graded exercise therapy for this cohort, because of the damage, it is really not where we want to go. So here's our contact details, because as we said, we know it's been a whistle-stop tour, so you can find some more information on our website, and there is a link, there's a section for resources for physios, but obviously anybody's welcome to look at it. You can tweet us or email us. I've also put the link up to the HEE e-learning module around rehab and rehabilitation, which covers some of those points. And I think we'd be happy to answer any questions, Rachel. Oh.
My video just doesn't want to start. So there we go. So wow, I mean, there is lots of questions. I'm going to try and consolidate some. I just want to make a note. I have posted on YouTube and on Twitter about the amazing resources that are available on your website and the podcasts. I'm going to focus on a couple of specific ones, which are around if you have a long COVID patient and they are currently exercising and not exercising based on the level of fatigue, do you just say stop exercising completely? So that rest part. And how long should they rest for?
So do you mean, so resting, I personally have been it depends on the severity of symptoms, and I'm not just talking about fatigue, I'm talking about all the other symptoms of post-exertional malaise that Nikki mentioned. I would start with a minimum of 4 rests a day at 20 minutes as a kind of general rule. The person may need more, and it's about encouraging rest when the person feels they need it. So yeah, that's a kind of rough idea, but some patients, you know, will have two 20-minute rests throughout the day, and that will be enough for them to top up their energy reserves.
I think people with ME would say actually that rest before you feel you need to rest as well. If you wait until you feel it, then it's too late.
And I suppose, Rachel, were you talking about people who are actually exercising and then crashing and then exercising and then crashing, and how to get to that stable position as well?
Yeah,
was that one of the questions?
It kind of links in with a couple of other comments about this approach requires a huge amount of discipline from the patient. So how can we encourage that actually exercise isn't going to be beneficial while they're still in this rest and recovery phase? Any tips? All I can say from my experience is that if people have tried to exercise and then seen how bad they feel after, you almost don't need to encourage them, because they've experienced it. I think it is quite a trial and error type
approach. So there's a little bit about how you can give them the science, like heart rate monitoring, if it's appropriate for them, and that helps guide them. But it's about explain, as it is with all our physio treatments, it's about explaining it. It's that shared decision making. It's making sure that they understand why you're saying rest. And I think it's that experience, isn't it? I don't know, Natalie, if you've had some quite keen exercises, haven't you? And
yes. Yeah, I think you're spot on, Michelle. Once they realise that the exertion is causing the symptom exacerbation, it's like a light bulb moment. Okay, so then resting is good for me. Yes, and unfortunately, it goes against some of our natural human instincts to want to do more to get well. So it's a lot of re-education around this. And then once the patient starts to notice the benefit of resting, then they're on board, and then it's about just keeping them on track with that.
I think I've also noticed the people I've been advising is that once they can chart their symptoms as well, so they're using the diary and they can actually see the link. Okay, so I did that one day and this is what threw it out completely. So it wasn't just the exercise, it was all these other cognitive activities, it was the emotional, the stress, the socializing, all of it contributing to their crashing or to their changing symptoms. So I think the people I've been advising is sort of to stop almost for a week or even 2 weeks if you can, get time off work and just start from basics. Start, what does getting up out of the bed do to me? What does having a shower do to me? What does getting my breakfast do to me? These really, really simple activities can really wipe people out. So especially showering. So, it's really important that they can see these patterns and see what is causing them the big problems.
And I think that's quite interesting. Sorry, Rachel, I was just looking at the comments where people saying that, we're used to the message, aren't we, that moving and exercise is good and helps us heal. So that point where Natalie's saying about how we need to re-educate that actually for this condition, you need to do things differently, which is quite hard, I think. But
so I think that the take-home message is clear. And again, look on the website for how you can approach that with patients, for the professionals out there. And it is almost reassuring people that rest and recovery is okay. One of the biggest challenges we'll have is a number of healthcare professionals obviously went back to work and are now off on sick leave with long COVID. Now I do have a couple of professional questions, if I could just get them in. So one is from this Cola's put a couple on. Is there any biomarker to measure fatigue apart from the fatigue questionnaire? It will really help us to know when to start exercising patients.
No.
No.
Not yet. We're working on it.
Yeah, there's no biomarker, and we tend to just recommend just a numerical pain rating scale or a sort of visual analog scale in terms of fatigue or any symptoms that they're having. So I think because none of the fatigue questionnaires that we put up there have been validated for long COVID or for ME, really, that you're better off just scoring it. And to be honest, I think that the bearable app, people are finding that really, really useful in terms of monitoring their symptoms.
Absolutely. The final question that I'm going to ask is, there's a lot of questions about GPs. So should GPs be referring on to specific fatigue management services when they exist? Is that just a straight yes? Or do you think it's just give the simple advice first? Because otherwise we have hundreds of thousands of patients now with long COVID, or what is probably going to be defined. What do you think?
I think that's a really tricky one, because I think if we felt that people were consistently getting that good information from their GPs around fatigue management, and then also it is a different approach to fatigue for this cohort, for like post cancer, your fatigue, your approach to fatigue is very different. So it's around, recognizing that it's a different cohort of fatigue, I think. So I think, yes, probably if we could upskill all our GPs with the basic information around fatigue management in this cohort, then absolutely, because you're right, otherwise the services are going to be overwhelmed, aren't they? But hopefully with some of the long COVID services coming on and some of the virtual groups and things that people are looking at setting up, that's going to help with that capacity issue.
And I think for the healthcare professionals out there, we really need to understand as a respiratory community those post-ICU patients that have PICS, that have post-intensive care syndrome, which we know exists anyway. We'll have patients that have post-viral fatigue, we'll have post-viral malaise, severe pneumonias. We know pneumonia kills young people, and we'll have COVID pneumonias. So we'll have mixed pictures. And then we'll have the patients in the community who've never been hospitalised, who are describing these horrific symptoms now, and which may well go on to be chronic fatigue syndrome. So, and we know we're 10 months into the pandemic now, so, you know, this is when we're really starting to see differences. So the final question, we are at time, is there any way that the acute healthcare professionals, so those working in hospitals, can identify those patients that might be more at risk of long COVID or not? Or should we just give people all of the advice that's admitted with COVID-19?
Really difficult.
To your resources,
really difficult, I mean, I've been advising people to use, you know, your pulse oxes, your blood pressure monitors, your heart rate monitors, to see how they're responding to exercise. And, you know, it gives you an idea if there's some orthostatic intolerances, so if there's any autonomic nervous system changes, and that's a really good clue, because as I say, a lot of people are struggling with their heart rate, you know, very strange heart rate responses. And then I would definitely be advising, if there is that, you know, to just get the heart checked out, the respiratory system checked out, make sure there's nothing, you know, pathological that's obvious, because unfortunately, you know, post-viral fatigue syndrome is really difficult, as you say, no biomarker. So it's picked up through not your normal blood tests, not your normal x-rays, and it's how they respond to changes in sit to stand, you know, and this post-exertional malaise. So if they can pick that up in the early stages, brilliant, but it is very difficult.
And that slide that Natalie showed with the sort of when to think about that it might be not progressing the way you expect on the subjective history, I get a little bit on my soapbox, so I'm not going to go there, but a really good subjective history and how they respond to activity is a big clue.
Thank you. Well, there's so much free resource on the website. Please go there. There is a question if there's any online support groups for patients. So can we just post some of them? I presume they're on your website as well, but if we just post some of them on Twitter. So Physios for ME, very easy to find, and please get yourself over there. And massive thanks to the speakers today. We have a 15-minute break, so please come back at 10:15 where we'll have the next section. Go and get yourself a drink, stretch your legs. Thank you.